Good morning, everyone. Thank you for your patience. My name is Jody Powell. I'm originally from Portland, Oregon. I completed my undergrad at Brigham Young University, Idaho in biology. I took a year to work in clinical trials as a clinical research coordinator, which includes all the care of participants in clinical trials. We looked at C. diff, new treatments, including antibiotics and fecal microbiota transplants. If you have questions about clinical research, if you're in your undergrad, something that you're interested in that, you can ask me later. But let's go ahead and get started with my internship project that I completed as part of my Master's of Public Health degree. Over the summer, I worked at Northern Nevada HOPES, mapping their patient population using a program called ArcGIS, which is the gold standard in many fields for mapping programs. So in Reno, there's a problem. There's a shortage of accessible, affordable healthcare. This is a problem that's seen nationwide. In Reno, it's extremely prevalent. So Northern Nevada HOPES seeks to provide accessibility and affordability for essential services. They're trying to fill the gap for that shortage of care. Why mapping? Mapping their patient population can help HOPES expand services and better target their outreach in the community. We'll start off talking about Northern Nevada HOPES, their services, and who they are. A bit of history. They began in a small repurposed motel to serve HIV patients only. HOPES stands for HIV Outpatient Education Services. They've since expanded their facilities in the same location and also their services. They now provide adults and pediatric medical services, including behavioral health, case management resources, which include aid in housing and transportation, delivery of medication to patients' homes, a wide variety of services available through HOPES. They also have on-site a harm reduction center known as Change Point. In that facility, they house their needle exchange program, the naloxone education, and free HIV, HCV testing on-site and in an outreach vehicle in the community. I spent considerable time in Change Point, the facility that's on-site on the HOPES campus. Fantastic people. Grew to understand a lot about harm reduction in our community and what our faults and needs are. HOPES, in their main building, also provides laboratory and pharmacy services. HOPES uses an integrated care model to provide one location for all the services that their patients may need, including their primary care, harm reduction, medical legal services, x-rays and diagnosis, a pharmacy on site, their case management and support services, insurance and eligibility, and their behavioral health services. HOPES strives to serve all patients regardless of their ability to pay. They see many patients that are below the federal poverty line and offer assistance in the form of case management, housing, insurance, help and discussions so that patients aren't refused care because they're not able to pay. So HOPES by the numbers, this graph comes, or this figure comes from HOPES' release of their 2017 data. HOPES in 2016 saw 2,085 pediatric patients. They had a total of 44,366 visits, and that's a total of 9,796 patients served, and that's a 26% increase from the year before. So HOPES is growing. They recently completed their new offices, which house their pods of adult and pediatric clinics as well as their behavioral health clinics. And they're rapidly expanding, trying to serve the patients in the community regardless of their ability to pay. They offered 6,880 vaccinations and immunizations, and they have 92% of their HIV positive patients with an undetectable viral load, which is phenomenal, meaning that their patients are being compliant with their antiviral medication. Also, through ChangePoint, their needle exchange program, that program also includes syringe collection and cleanup. So 900,006 syringes were disposed of safely through the syringe program offices, which is phenomenal. Northern Nevada Hopes is recognized as a Federal Tort Claims Act affiliate, a patient-centered medical home, National Health Service Corps member, and is a federally qualified health center. And as you see, Troy is typing now. Feel free to ask questions via the chat box at any time. We'll take a moment to answer your questions whenever you have them. At Hopes, I worked in the data science department. And my preceptor, Gar Gautam, was a phenomenal resource for me, very knowledgeable, and he knows what he's doing in data science. The department provides more than just reports. They provide solutions for the barriers to care for Hopes patients. And they also investigate how to improve workflow for better delivery of service. The integrated model that Hopes uses for its patients is the same model that they use within the structure of the facility. Everyone relies on each other to complete projects and make healthcare better accessible to their population. A quick overview of ArcGIS. ArcGIS is a software program published by Esri. A link is provided there for Esri's home website. We used ArcGIS Pro, which is the new state-of-the-art mapping software recently published by Esri. The benefits of using ArcGIS Pro, and for those of you who may use this in your clinic, your facility, or during future internships if you're a student, this platform is more user-friendly than the standard traditional desktop version, which requires a lot of training and know-how. If you don't use the desktop version every day or use it infrequently, you may forget how to use the system. It's that intricate and that complicated. So the benefits of ArcGIS Pro is user-friendly and provides a built-in geocoding services, which transforms patient addresses into XY coordinates so it can be plotted on the map. It also yields high-quality maps, and it also provides useful tools for further analysis. So just an overview for you potential users of ArcGIS. Advantages: there is a nonprofit license available. So if you represent a nonprofit, you can submit their nonprofit form and potentially get a free or reduced cost license for ArcGIS, which would include your desktop version and also their new platform, ArcGIS Pro. The Pro and online versions are simple and easy to use. There are, however, some drawbacks. ArcGIS is very expensive. It's billed on a yearly license. The traditional desktop version, like I said before, requires extensive training. And also customer service can be hit and miss with the company. There are several instances where we didn't get a call back and we were wondering what we would do for the day. So data handling privacy, this is a very important point with this sensitive topic, this issue. All the maps that were created and all the data was handled on Hope's internal server. Maps used in this presentation have been approved. They contain no identifiable patient information. Most maps created, unfortunately, cannot be shared to protect patient privacy. This is due to the nature of the maps showing points geographically which could be identifiable as patients' home addresses. So now a review of what I did during my internship. So what did I do? We mapped Hope's patient population by their comorbidities and also socioeconomic status. How did we go about doing this? We completed a needs assessment for 2017, which included a variety of counts of patients by comorbidity, by their diagnosed diseases, also by their homeless status, by their FPL, which is federal poverty level, and also different metrics available there. From that needs assessment, we identified patients that we wanted to map. We mapped our target populations, or I should say the sample of our target population, which is HOPES patients. And from that data, looking at those maps, we outlined and discussed interventions. This internship was a proof of concept for the mapping being beneficial for HOPES. So there is space for further analysis and deeper inquiry into what these maps mean. Why did we do this? We wanted to understand HOPES patient distribution, identify areas for potential expansion, and identify areas for increased outreach. HOPES is a fantastic resource in our community. It is centered on 4th Street in Ralston, 5th Street in Ralston, but they also provide a lot of outreach in the community with their mobile health clinics, where they go and outreach to different people in the community, and also their mobile outreach for Change Point, which is the needle exchange program. They don't exchange needle in these mobile outreaches, but they do test patients using rapid tests for HCV, hepatitis C, and also HIV. These are the key health issues which were addressed during this internship. Infectious disease control. We worked with the Harm Reduction Center to map their outreach sites and also look into what we can do to target the outreach to find the highest number of individuals that will test for HCV and HIV, and also recruit for needle exchange. We worked with the Ryan White program, increasing their accessibility, finding out where patients with HIV were located in Reno. There are extensive services provided through the Ryan White initiative, including transport for HIV patients to bring them to their clinic and delivery of medication. We looked at chronic disease management, particularly diabetes and hypertension, the relationship between HOPES locations and their partners' locations throughout the city, and management of diabetes and hypertension. Also, in partnership with the Financial Medical Partnership, we looked at federal poverty level data to understand the distribution of patients. So I can't go forward without saying a big thank you to HOPES for the fantastic work environment that they provided and the cooperation throughout the departments that they provided. So this map here, some of you may be familiar with this system, comes from UDS Mapper. Data from most clinics in the area are provided into this UDS Mapper if they're a participant. And from UDS, you can run reports on federal poverty level data. You can run reports on diabetes, hypertension, but all of it is at the aggregate level. So you don't get to focus down and create maps that are specific either to your clinic or to your research questions, whatever those may be. You can zoom in, you can identify your service area, but this tool has limitations. On this map, we've plotted all of the outreach locations for HOPES HOPES Change Point Needle Exchange Program. And as you can see, the map is crude, may not provide as much detail as could be desired. This is the same map using ArcGIS Pro. And what we've done here, this is a heat map of HIV patients. So a heat map is a point density map that uses a color gradient to express density of patients. So the color gradients that you see here, like this yellow, which would be considered a hot spot, is centered around HOPES. These locations down here with this bright centers here are also hot spots. You can see throughout the map points which are warmer than others. So the benefit of this map, it shows you focal points of patients and where they're concentrated. If you were to look at the same map, just a point map where all patients are labeled individually, they would be spread out in dots around these focal points.
Jody, so I have a question about that. So the heat around HOPES, do you think that's skewed data at all because the patients are closer to HOPES so they have quicker access?
Yes.
Okay.
Thank you for asking. So This hotspot and the data here is skewed significantly because Hope serves many homeless patients. And if they don't have a primary address or a home address, Hope's becomes the default for their address. And so the hotspot that you see around Hope's is a function of homeless population using Hope's as their primary address. Thanks, Troy, for that question. Did I answer it sufficiently for you?
Yeah, absolutely. That's great.
Okay, perfect. So as you can see on this map, and if we were in the software, we could zoom in and zoom out, and the color gradients change depending on your elevation off the map. You can see the outreach locations in some instances correspond with hotspots up here to the north, around Hope's, just north of Hope's, and of course downtown where shelters and outreach locations coincide to increase concentrations of HIV patients. You'll also note something that we discovered while mapping is the lack of outreach in southern Reno. So here, this main street here off the airport is Plum Avenue. So south of Plum, near the airport, 2 hotspots that should be noted that have no outreach close to them. So here in this map, we've identified locations for potential expansion of outreach. And ChangePoint is continually finding new locations to outreach in the community to provide free testing for HIV and HCV. The reason that we chose HIV as our heat map underneath these points is just to gauge the concentration of HIV patients known to Hope's and showing where a likelihood of finding more HIV patients might be. So there are some key factors to consider while mapping. It's important that you identify your target population. It's important that you know you're looking just at, say, your clinic's population. In this case, our target population is Hope's, all patients that receive services at Hope's. And then we further look for patient diagnoses of interest within that target population. It's important to understand context when looking at these maps. So my wife and I moved here about a year ago, exactly, and we moved here without a car. So that meant that we rode our bikes and took public transit everywhere across Reno. So we got a street level view of the neighborhoods that we passed through and also the times that it took to travel via public transit or cycling. It's important to note that many of Hope's patients utilize public transportation to get to their appointments at Hope's locations, either public transportation or a combination of walking, biking, and public transportation. It's shocking to think that from Meadowood Mall, it can take over an hour to get to the 4th Street station, depending on the bus line and the route. And then from 4th Street station, using a connector bus to Hope's, or walking from the 4th Street station to Hope's could take an hour and a half. So that's a substantial barrier to care in Reno. Reno does have a functioning public transportation, but it's slow and can be inefficient for Hope's patients, especially those who are coming from areas down here in the south in Reno. It's a very long bus ride / very long ride walk. Homeless population in Reno. This is not unique to Hope's. Our hospital systems see homeless patients. Private clinics may see homeless patients. But it's extremely difficult to find out where homeless patients are living, residing. Homelessness in the traditional sense, we might think of people on the streets, but also it applies to those who are couch surfing or may not have an apartment of their own, who are staying with friends. These homeless populations are in a very precarious situation and thus open themselves to a host of negative health outcomes. So it's important that we know where these homeless patients are usually seen or where they're usually sleeping at night, there's a host of factors that are contributing to the negative health outcomes of these homeless people. And I'll address a proposed solution to homeless population tracking. I'm hesitant to say homeless population tracking, but we need to know where our homeless population is residing within our city. So, with the Financial Medical Partnership, this is a map that we created to show HOPE's distribution of federal poverty level data, or patients within each federal poverty level. So, in this corner you'll see the federal poverty level 0 to 99, 100 to 199, 200 to 299, and 3 to 399. The largest groups, of course, being seen at HOPE's are in the 0 to 99% of the federal poverty level and 100 to 199% of the federal poverty level. Of interest are the hotspots seen around Reno, focused in 3 main areas around Odie Boulevard and Sparks, downtown Reno, and then South Reno near the airport, Peckham Lane, off of Moana, Neal Road, areas that show the highest density of patients living below 99% of the federal poverty line, at or below 99% of the federal poverty line. And then you'll also see some disbursement out from those hotspots. What's really interesting to me, and should be noted, is the change in distribution. Once you reach that 100% of the federal poverty line level, there's a distribution that is much larger in the patients. So we all know, hopefully we all know, that federal poverty line is a predictor for health outcomes. It's linked in so many different ways through the housing that these people are living in, the neighborhoods that they're living in, the prevalence of tobacco use, drug use, a myriad of factors that are contributing to negative health outcomes in these populations. So it's important to know where the poorest of the poor are located in Reno, and also of interest to see how a change in poverty level can lead to increased opportunities to break out of the traditional hot spots of poverty and expand throughout the city. Of course, you'll note changes in distribution for the higher federal poverty level data, distributions out into richer neighborhoods, of course. Of interest to HOPE's is the suppression of viral load for patients diagnosed with HIV. This is accomplished through adherence to the prescribed taking of antiviral medication. So this is an HIV suppression heat map from July 2017 to June 2018. This is the category defined as suppressed, meaning they are taking their antiviral drugs, and this is a very good thing. So you'll see patients are very suppressed around downtown Reno, near HOPE's Clinic, which is located here, and just south here, north of Moana Lane. We compare this map to HIV suppression in the same time frame, which are not suppressed. This is a zoomed out map. The change in perspective does not change the focal heat point down here by the airport. It does highlight that within the same area as the previous map, there is still suppression problems close to HOPE's Clinic. What we see in this map, the non-suppressed map, which is different than the previous map, is a hotspot of non-suppression down here, south of Moana. And you'll note previously the hotspot was north of Moana Lane for suppression. South of Moana Lane, a hotspot of not suppressed data. And again, this is preliminary data. This is a proof of concept showing what we can do with mapping. I'm hesitant to draw conclusions from this data and these maps. So just be aware of that.
There was a question here. Could you explain a little bit more about the poverty levels?
Yeah, absolutely.
So what those 0 to 99, 199 mean?
So federal poverty level data is calculated using household income. The federal poverty level is used to calculate insurance rates, whether you qualify for reduced insurance, Medicaid, excuse me. You've caught me on the spot. I should have had some numbers memorized, but the federal poverty line is somewhere around 40,000 for a single person living at home, and it increases with the number of people that are living in your household who are dependent on that income. Right? So if you're living below the federal poverty line, it means that if you're a single person making under $40,000, you're going to be struggling to make bills potentially, pay for healthcare, insurance, several other things. So it's a metric that the government has established to determine poverty in the United States, if that makes sense. Okay, so the potential, if you're living below 100% of the federal poverty line, the literature suggests that that is associated heavily with negative health outcomes. And as you move up the scale in federal poverty level, that those negative health outcomes are reduced for many, many factors. So, project impacts for our patients at HOPES. We were seeking for potential for increased outreach for the potential patients at HOPES. So meaning that when we're out in the community, we're targeting populations that could use our services, which we could use the federal poverty level data to determine which neighborhoods we need to focus on for outreach. That means boots on the ground, advertising in parks, advertising in many different ways. Expanded services for in-need neighborhoods. So again, focusing on neighborhoods that are in the greatest need based on their poverty level. Also, the known disease from HOPES that we have, looking at maps of, let's say, diabetes or hypertension, looking for hot spots where we have many patients that are diagnosed with diabetes. Could be an indication that we could focus in that area to recruit more patients, potentially for diabetes or for other diagnoses. And then all of this is leading for better access to affordable healthcare. That is the major outcome that we want to produce from HOPES.
So should we consider all hotspots of HIV patients, suppression, non-suppression, and others skewed by the location of HOPES?
Yes. So it's a potential confounder of data. Suppression here would be skewed by homeless population. Remember that their address would correspond to HOPES, right? And so a hotspot near where HOPES is would be indicative of skewing of the data or over-reporting of data or incidence of, I guess, prevalence of HIV in that area, if that makes sense. So, recommendations and potential for using mapping. Whether you're a healthcare provider looking for something to better understand your patient population, or whether you're a student looking to get into a niche market and make yourself advertisable for potential schools, potential jobs, whatever it is, we should be focused on recommendations and potential for what we did with this data, right? Or whatever you're going to do with your data. So for case management, who provides housing assistance, food, transportation, many different helps for HOPES patients, they go out into the community and they reach out to homeless populations, particularly, let's just focus on that. So the potential for this program or recommendation for using this program, ArcGIS, would be to track our homeless population and where they're living and where they're seen the most. And so this could be accomplished during interviews with case management when they're out in the community saying, hey, we've got these resources for you. During every interaction, they could simply drop a pin on their cell phone saying, I spoke to someone here, this is what we spoke about, and yes, they're interested in services. Something as simple as that. And then using those coordinates that are dropped on the pin on their phone, plot that on a map. So when case management goes out, they know where they've had contact with people, who was interested, how many people were interested in that area. And that can direct outreach for other branches or departments at HOPES. For ChangePoint, they already count and track the number of HIV and Hep C tests that they provide to the community. And they also are tracking the % positive. So in addition to that, I suggest that we drop a pin on our phone so that we have geographic location of where these tests are done. And then also asking these patients if they're homeless, where they frequent the most. There are difficulties for collecting addresses in an outreach environment. We would need these people to be HOPES patients in order to get their address, which is a HIPAA-protected parameter. So there are complications there and limitations to what we can collect in outreach. But if we can get an idea of where these people are located in relation to where we're testing, that would be a great help to target our outreach and our testing in the future. Right? Yes.
Oh no, you can finish up this slide, then we'll get to the question.
So potential for HOPES expansion. HOPES is growing hugely. Over the last year, they've seen huge gains in their patient population and the services they're providing, and they want to provide more because it's a needed resource for our community. So looking at maps based on our HIV population, our HCV population, our federal poverty level data, we hope that this mapping software can be used to determine better locations for outreach for HOPES and potential expansion of services, whether that's through partnerships or expansion of physical buildings. Go ahead.
Okay, so question here, is HOPES looking for volunteers or grant funding?
Yes, always, always. So if you look on their website, a great person to contact would be Rebecca Ratius in the HR department, Tiffany Ogle. They could get you in contact with the people for volunteering. So Rebecca is a volunteer specialist, and she's great to work with. They are always looking for volunteers, yes. Let me just give a pitch out to any of you who are undergrads or grad students looking for internships. HOPES, I think, is the #1 place to work. And it was voted the #1 place to work in Nevada, and I think that's true. The community and the sense of purpose that you feel there, I don't think I've ever felt in any other workplace or community. So if you're looking for a great opportunity to work with some of the best people, doing the best things, the most needed things in our community, HOPES, I think, is the place to go. So that's a prompt for you who are looking for internships or volunteer opportunities. HOPES is a great place to go.
And then as far as funding, you're a federally qualified health center, right? So what does that all entail?
So that opens up opportunities for HOPES to receive increased grants from the federal government. They've met certain qualifications for providing essential care that allows them to receive increased money from the government. So that's a federally qualified health center.
There's a question here. Any discussion about directing the legal marijuana taxes towards programs like HOPES? I think right now it's going into what, the rainy day fund, whatever that is.
Yeah.
And it was supposed to go to education, but
yeah,
it's going.
So it's funding at the state level can be complicated. For example, countries have rainy day funds. Norway has a rainy day fund that they use for powering their electric cars and providing discounts for electric cars, for example. So I think it would be a great idea for legal marijuana to be used for better health outcomes for low-income, underinsured people. So, future steps using what we've done so far with mapping. ArcGIS has built-in tools, and there are also free platforms. Geoda is one of them that provide distance analysis for the data that you've mapped, right? So it can tell you what's going on, how far do patients live from the clinic, what is their drive time, for instance. This analysis could yield benefit to Northern Nevada Hopes, seeing how far their patients are traveling to get to Hopes. For services, putting clinics or partnering with people closer to those places would be extremely beneficial. Also, analyzing federal poverty levels in chronic disease maintenance. So soon I'll be writing a professional paper. I'm very interested in looking at poverty levels and their association with chronic disease maintenance. So we created a map, which unfortunately I couldn't show you due to confidentiality reasons, that plotted federal poverty level and diabetes A1C levels. So we could see where people were controlling their diabetes and where people were uncontrolled. A larger A1C meaning that their diabetes was uncontrolled. So initial looks, and remember all this data is preliminary, initial viewing of this data appears that control of diabetes is very connected to federal poverty level data. That people in poorer areas are less likely to control their diabetes even when they're close to Hopes. So my hypothesis is that patient poverty affects disease outcomes more than proximity to care does. Whether that's true or not is yet to be tested. There's a lot of research out there linking poverty level to chronic disease management. So thank you very much for your time, and thank you for Project ECHO, and thank you to Hopes and my preceptor Gar for the great opportunity it was to look at this data and also to present it to you. So we'll open the time up now for questions and answers.
Yes, please write in your questions via that chat box or the Q&A function at the bottom of the screen.
If you don't have questions, that's all right. While you're thinking about questions and why they're coming in, just words of advice for undergraduate students. Do your best in your undergrad. Look for great internships. Hope is a great opportunity. I know you're graduating soon if you're required to watch the seminar. I took a year off after school and I worked. That was a fantastic benefit to me. Whatever you decide to do, whatever's right for you, make it happen and do it, guys.
Some people are asking who you are. Could you just introduce yourself real quick again?
Yeah, so my name is Joey Powell. I'm an MPH, Master of Public Health candidate at the University of Nevada, Reno. I have a bachelor's degree in human biology. I have experience in the community service industry, health outreach, and also clinical trials.
Okay. Do you think a lack of information to people below the poverty level also affects their access to care and Hopes?
Yes. A lack of information being either a lack of information through advertising or a lack of education, formal education, definitely affects people's understanding of the healthcare system and also their understanding of resources available and disease. So education level is always involved in people's health-seeking behaviors, right? So you're more likely to seek healthcare that you need if you have an understanding of the disease process. If you're not intimidated by, let's say, the hospital or medical clinics, if you're not intimidated by that, then you're more likely to seek care.
So someone thinking about getting their master's in social work, would that be beneficial to use in the public health field?
Yes, absolutely. Social work is very closely tied to public health. There's a master's in public health, which is social and behavioral science, which is your emphasis, which might be it's an excellent coupling of the two. So I would highly recommend that. Social work, if you get a master's in social work, you can do a lot of things that are very related to public health. The director of Change Point, the Needle Exchange Program, which is extremely linked to public health, is a social worker.
Question about building small homes for HOPE's patients. Do you know when that project's going to be started?
I do not know any information about that.
We refer a lot of patients from the emergency department for follow-up within 2 to 3 days, work as an RN in the emergency department. On average, how quickly are these patients able to get in? Meaning, are they usually seen within the recommended follow-up time?
HOPES strives to see the patients as quick as possible. Same-day appointments are difficult. I cannot give you an official time frame. You can contact Jerry, the coordinator for patient care at HOPES. He can give you a specific answer on that. But I do know that they try to get them in as quickly as possible. Unfortunately, HOPES is struggling to keep up with the demand for patients. And so they're working hard to expand their services and get as many SO people in. So that's the question there.
So what got you interested in this topic? How did you get started?
Excellent question. So originally, I was working in clinical trials. I was going to pursue a profession, auditing clinical trials, and it just didn't turn out to be right for me. So I pursued a master's in public health, primarily interested in infectious disease. And so I was talking to Gerald Dermid at UNR, who is the coordinator for internships for the master's level and I believe undergraduate degree seekers. And he turned me on to HOPES after I expressed my interest in infectious disease. And he said they've got this program going where they want to try to map their patient population. So thanks to Gerald, that's how that got started. I've also always had interest in cartography, I guess you'd say. And mapping is very interesting to me. So that's how that started.
Okay. What would be the best way to give beneficial and appropriate information about interventions to impoverished communities?
The best way is always to work within the community. So if you can find one person in that community that will listen to you, that lives in that neighborhood, that is fully on board with what you have in mind, what you want to bring to that population, that community member is the most impactful. You can have billboards, you can have radio advertising, but you need a spokesman in their community that has had success with you before. And there are a lot of HOPES patients that have had success through HOPES. So using those members in the community to reach out to their neighbors, to reach out to their friends, is the best thing that we can do, not only to advertise to people and let them know about the resources available, but also to help them seek care, to help them get to some place that will accept them, that will accept whatever insurance they have or don't have, will also be beneficial.
A question here about getting involved in an internship with HOPES, not for academic credit, coming in the spring semester. What would you recommend?
If you're a student, contact Gerald Dermid and contact Rebecca Reyes at HOPES. So if you go to HOPES, nnhopes.org, look up Rebecca Reyes. She can help you and give you instructions for your particular situation. There you go. Rebecca Reyes, credentialing and volunteer specialist.
Thanks. Someone shared her email address in the
Perfect.
chat.
And I see a comment there that you should actually contact Melanie Flores for undergraduate internships. And she's located in Lombardi. And you can find her information on the CHS website.
Does HOPES provide continued primary care services, or are patients asked to eventually seek care elsewhere?
There are patients at Hope that have been receiving care there for years and years. So HOPES serves as a primary care clinic, and patients are welcome to continue their primary care as long as they want.
Okay, we've got a few more minutes if you have any other questions before we wrap up. Okay, I don't see any coming in, so thank you so much, everyone. Oh, wait, one more. Can you talk about your clinical trials with C. diff?
Yeah, I love C. diff, guys. Let me tell you. So, for those of you who don't know, C. diff is short for Clostridium difficile, which is a bacterial infection. It's actually a bacteria that lives in your gut. It can be present normally without any disease. But what can happen if your immune system is compromised, the good gut bacteria are somehow compromised, C. difficile, Clostridium difficile, this bacteria can overgrow and cause disease, right? It's commonly found in people who take antibiotics, but antibiotics do not cause C. difficile. They create the environment for C. diff to overgrow. That's an important difference there. So, I can share some details about what we worked. This is public knowledge. It's been published. Actelion, a drug company from Switzerland, was working on new antibiotics to treat C. diff infections. And preliminary results proved successful in adults. And remember, this is published data. It's publicly available, so I can share it. Preliminary results were good for this new antibiotic. We also worked on fecal transplants using dehydrated bacteria in pill form given orally to replenish good bacteria after a course of antibiotics, vancomycin, which is the standard of care for this facility that I worked for. People would take a course of vancomycin to destroy the infection and then replenish good bacteria using a fecal transplant pill, which was composed of bacteria that had been dehydrated and encapsulated. We also worked closely with the gastroenterologist doing the traditional fecal microbiota transplant using donor stool, which is given via enema into patients after their course of antibiotics. I worked with Martha Buitrago, who is an infectious disease doctor, and Richard Nathan at Idaho Falls Infectious Disease. And it was a great experience. Saw and did a lot of things that I will never forget with C. difficile. Was that descriptive enough for you?
Somebody shared here. It's interesting because my grandfather was part of that program when he contracted C. diff.
Very cool. There are a lot of clinical trials going on with C. diff. A lot of different companies putting out different drugs to be tested. So if you're interested in clinical trials, you can just search Clinical Research Coordinator in Reno. I'm sure there are plenty of facilities in town that conduct clinical trials. Usually they're in the privately owned clinic areas. Some hospitals do clinical trials. If you're interested in the administrative side, you can Google, just Google clinical trials. You can Google clinical trial monitor if you want to work for one of the big companies that audits and performs the clinical trial at the corporate level.
Question here, who to contact to share some feedback regarding their internship at ChangePoint?
Could you repeat the question?
So they're just interested in basically sharing feedback with staff at Hopes about their internship at ChangePoint.
Yeah. So if you want to share feedback, if you did your internship at ChangePoint, I would talk to the director of ChangePoint or contact Rebecca Ratius. So if you were an intern there, you should have dealt with her or had dealings with her. Not dealt with her, but had contact with her. So I would contact her to share your feedback and get in touch with your preceptor or whoever coordinated your internship.
Can you address a little bit more about the link between public health and social work?
I am not myself a social worker, but in public health, there's something that we know as the social determinants of health, which is a long, long list of social aspects in a person's life that has direct or indirect effects on their health, right? So if you grew up impoverished, it's likely that you lived in a neighborhood that may not have had the best environment. There may have been pests present, pollution present, whatever those health factors are that are more concentrated in a low-income area affect your health, right? If you have air conditioning in your home, for example, you're not going to breathe as many pollutants in the air, right? If you live in a low-income area, you're more likely to have your windows open or not have air conditioning, so you're breathing the outside air, which could lead to asthma further in life, just as an example. Hope that answers your question. But as a social worker, you'll work closely to help people in circumstances that may be negatively affecting their health outcomes. And you can work as closely as you want with public health. You may even work for the public health department as a social worker.
Comment here that both St. Mary's and Renown offer clinical trials in several disciplines and have clinical research study coordinators on staff, including oncology, cardiovascular health, neurology, and population health.
Excellent. If you are interested in medicine at all, if you have plans to go into the healthcare field, whether you want to be a PA, a nurse, a doctor, and you're looking for clinical exposure to patients, I highly recommend looking into clinical trials as a potential option. Because you get direct patient care. I was on the phone constantly with my patients under the purview of the doctor. I was in the room with them, both for their exams with the doctor and also performing the procedures. My direct supervisor would draw blood. She would take the blood pressure as a clinical research coordinator. So you have plenty of direct patient contact when you're in that setting, dependent upon the design of the clinical trial, of course.
Any other questions? Please feel free to keep writing your questions in the chat or the Q&A function. 5 more minutes here. Alrighty, I think we'll wrap up for the day. Thank you so much, everyone. Thank you, Jody, for presenting. This was great, very informational. We'll hope to see you back next month. Thank you.
Thank you.